Okay, so let's take a look at what our goals for today are going to be. It's really a holistic overview of ultrasound probe reprocessing, research on infection risk with ultrasounds for the Spaulding classification and federal guidelines, traceability, ultrasound infection prevention expert group, and the tools for standard infection control for ultrasound. I think you'll be very pleased with a lot of the work that's been done by a group that we'll have a slide and show. I'm very proud to have been asked to work with them on producing I think a very extensive toolkit that is available to everybody, and I believe that you have these little cards that will tell you how you access that. So what is an ultrasound? Ultrasound probes are heat-sensitive, reusable medical devices used to visualize the anatomy in a variety of procedures. Now, one of the things I will tell you that when we did a review at our university centers, I'll show you a couple of slides about the initial process of trying to identify the number of devices that are used, and I think it was an incredible eye-opener for us. The whole thing about overviewing these kinds of technologies is the issue of traceability. Remember that in the most basic thing that we do for medical devices is we go in the following sequence. It's really cleaning, followed by disinfection, sterilization, storage issues, and next patient use. And these are the kinds of issues that we have to address with the kind of ultrasound devices that are available to us in our institutions that are so widely used today. And if you even look into some of your ancillary clinics and all these kinds of different associated physician offices, they will have these kinds of devices. So I think that this is a issue that I think that we're going to have to address over the next couple of even years about identifying and doing the right thing about these. Well, this is a Joint Commission directive that was put out, and I thought what was very interesting about this is that they sum up their survey results occasionally, and this was one of them. And it said that 74% of all immediate threat to life declarations were from improper sterilization or high-level disinfection of devices. Non-compliant with TJC infection control standards has increased between 2009 and 2016 in hospitals, critical access hospitals, ambulatory and office-based surgery facilities. I'm not going to ask you how many of you have gone through this and how many of you have had at least a surveyor directly ask you questions like that, or certainly whether you've had a citation about that. But believe me, I've been through this for many years and many surveys, and this is becoming one of their top issues to look at. So the question is, have there been studies which show that there have been outbreaks associated with these kinds of devices and even patient deaths? And the answer, of course, right here, as you can see, the answer is yes. There is a number of articles that have been published in the literature. You'll see the list of them right there. And very interestingly enough, one of them was an alert from the UK that was dealing with a patient death from hepatitis B infection thought to have been transmitted by improperly reprocessed endocavitary ultrasounds. Not all infections, though, are published in peer-reviewed journals. Remember that it's not necessarily in all areas that it's obligated to report this. And the other thing that I think is even more profound is that we don't necessarily make the link between using a device and a patient developing an infection. And that's something that I think that we need to look at in a different angle today. So is there improper reprocessing linked to increased infection risk? Here's a study from Scotland, the NHSN government, their government health department, that demonstrated an epidemiological link between insufficient endocavitary probe disinfection, in other words, low-level disinfection, and increased infection risk. And it linked national patient data sets that were published between 2010 and 2006, and those were analyzed for positive cultures and antibiotic prescriptions as proxy for infection risk. In other words, were infections with these devices associated then with also the prescription of antibiotics because of the possibility that they picked up an infection when they were undergoing these kinds of procedures. So, again, as I mentioned to you, I was very, very proud. I am proud about having been asked to join an expert group, and these are some of the people that are really expert in the field about disinfection and sterilization. And basically what we were asked is to review what the situation was in terms of the problems that were associated with these kinds of medical devices, and then to do assessment as to how to best construct educational materials in order to better understand the process on how you can identify these items, which is the possible risks associated through risk assessments, and finally giving tools on how to go ahead and try to identify these, particularly in the vast number of different departments that are associated with our healthcare institutions today. So I did some background reading when I was asked about this to go back to a model which we all still use today. And this gentleman named Earl Spaulding was really a genius. He came up with a model more than 30 years ago that basically tried to do one thing, is to classify risk associated with the use of certain medical devices and associate that with potential risk in terms of the body sites that it was being used on and the potential for transmitting an organism while you're using any kind of medical device, whether it was invasive, et cetera, et cetera. And it really is in 3 different levels. And it's still very, very applicable today. So the classifications go as follows. At the very top of the pyramid, we have what we classify as a critical device. And these are devices that contact sterile tissue or vascular system. And what is advocated here in this model is that they undergo a sterilization process. And we know that there are a vast number of ways that we can sterilize medical devices. I won't go into that in particular. But the real goal here in that category is to kill off all viable microorganisms. The middle category is those that are semi-critical. And these involve procedures that contact mucous membranes or non-intact skin. And that's a very, very important part of that designation. And what is recommended here is to do high-level disinfection. And the goal is to affect all viable microorganisms to be destroyed except for bacterial spores. And at the bottom of the pyramid is non-critical. So these are procedures in which contact with intact skin only. So in other words, no breaks in the skin. We're not dealing with blood or body fluids, et cetera, et cetera. And this is advocated to be disinfected at a low level. And it destroys most vegetative bacteria and viruses, except for bacterial spores, mycobacteria, fungi, or other small non-lipid enclosed viruses. So one of the first steps to be done was to conduct a national survey. And this was published in the American Journal of Infection Control. And here are some of the key findings. Ultrasound is used in almost every single healthcare department. Is anybody here surprised about that? My surprise about this is the extent of different departments that a lot of us may not have even been aware that they had. And the other surprise to me is that not only that so many different departments use ultrasound, but that they use what? Many different devices. and that you know, and I know I won't even ask for a show of hands. How many of you were involved when they were, you know, to be asked of, oh, by the way, you know, infection preventionist, how is it that you are recommending how to clean these devices? They were brought into the institutions. They were used all the way in ancillary areas where we had no idea, et cetera, et cetera. And there's a wide variability in disinfection practices suggests the gaps between guidelines and practice. So if you get a copy of this, I think this is some wonderful findings in this survey. Let me tell you a little bit of my own experience. Having had these, you know, revisiting these concepts, what I did was I asked our biomedical engineering department to send us a list of all these ultrasound probe devices that were being used throughout our facility. And we have a main campus that right now is about 625 beds, and we have other ancillary hospitals as well. So what did I get back? You know, little did I know that they would send me a printout that was 16 pages long in type that I said, okay, where's my magnifying glass here to read this, of so many different manufacturers. And not only within departments, they use different manufacturing devices. And the thing about this as well is that they don't have records as to what are they used for. That was the next thing. In other words, we use this list to send it back to the departments that ask them what are you using these devices for? And guess what? Some of them told us that they use the ultrasound machines for more than one purpose, not just one single purpose. And the slide that you see on the right-hand side is is an example of one of the manufacturers' information that we looked up for each of the devices so that we could try to get an idea of what they recommended in order how to disinfect their devices. The problem with this is is that when a manufacturer sells you a device like that, they don't necessarily know what you're going to use it for. And how does that fall into the Spaulding classification? So this was some of the results. Is a reprocessing practice for intraoperative and biopsy procedures. These can be improved. This, you see the table here that says here, the percent reporting probes high-level disinfected or sterilized. So as you can see in the survey, practitioners had sent back information to say when they used it in an endocavitary procedure, 96% of them used high-level disinfection or sterilization. Terrific. But go down the list here at some of the responses. Intra-op, 85%. Biopsies, only 59% used one of these processes. And non-intact skin, 55%. So generally, endocavitary processing practice was consistent with guideline recommendations, as you'll see in a minute, and high-level disinfection sterilization for probes used intraoperatively and during biopsies was lower than what we would expect. So here are two very, very important documents, one from the CDC and the other one from the FDA, which directly address the use of these kinds of probes. And let me read them briefly to you. The CDC says the following: ultrasound probes used during surgical procedures also can contact sterile body sites. These probes can be covered with a sterile sheath to reduce the level of contamination on the probe and reduce the risk for infection. However, because the sheath does not completely protect the probe should be sterilized between each patient use, as with other critical items. If this is not possible, at a minimum, the probe should be high-level disinfected and covered with a sterile probe cover. And the FDA says the following: for clinical applications of a semi-critical or critical nature, example, intraoperative, transrectal, transvaginal, et cetera, that you see there, says labeling should recommend, when appropriate, the use of sterile, legally marketed probe sheaths. Note that the use of sheath does not change the type of reprocessing that is recommended after each use. And why would that be? because there's the possibility then that the sheath could break during the procedure, could be punctured, and if you get the ultrasound probe close to the area where you're doing an injection or actually using the needle, you can actually contaminate the ultrasound probe with the body fluid. This is one of the answers that we had when we did the system review at our facilities, is how are we going to provide the correct kind of sheaths and gel to be used? And how many of you have had the opportunity to do rounds and take a look at your machines and what they're actually using? And what I found in our institution is that they had these wonderful, and I don't have a picture of it, I'm sorry, had these wonderful multi-use bottles, you know? How many of you use those that are blue in nature? And how many patients would it be used on? Was this being contaminated, et cetera? And you would find them in clean utility rooms right in the ultrasound machines, and you would ask questions and people would go, well, that's what we were being given. So we changed that kind of process of what we were going to make available. And this is just an example of a kit that has the sheath and the gel all together so that we can then standardize it, and that would be the only choice that they would have when they do a procedure in a certain location. Reprocessing practice varied across facilities for external ultrasound procedures. Here we have, for example, procedures such as injection, central line placement, and peripheral line placement. And these are the percent reporting probes, high-level disinfected or sterilized. Take a look at these numbers here. So, for example, if we look at central line placement, and in my career, I must have seen a good 200, 300, 400 procedures of clinicians doing central line placements. And I remember when I was if you want to say a young practitioner, I never even thought twice about that. I was so much more concerned about like the kits that they were using and how they prepped the skin, et cetera. And I never thought about the ultrasound that they were using. And take a look at some of the responses nationally about this kind of thing. So reprocessing practice was varied for ultrasound-guided percutaneous procedures. And if the probe contacts the sterile puncture site, the probe would require sterilization or high-level disinfection and sterile sheath, according to Spaulding, the CDC, and FDA. So in this drawings, here is an example to try to illustrate procedures such as nerve block, centesis procedures, injections, etc. And as you can see, I don't know whether this works here from this distance, but what you can see here is one of the most important thing is how close does the probe get to the actual insertion site. And even if you use a sheath here, the practicality of it is that this potentially becomes contaminated because of the approximation here. And if you come to the next lecture that we're going to have today at 9:30, we'll show you some video evidence of this kinds of practices, because we did review that in the real world to try to show that this was actually something of great concern. So what are the practical limitations to applying Spaulding? Well, this is part of the reason why we came up with a toolkit, because the problem that we have to start out with is, number one, is who are the people that are doing it in your institution? And it's not a matter that, you know, physicians are doing it or nurse practitioners. Remember that what involves also is skill level. So you can go into one single department that's doing it, and you could have someone that's been doing it for years and they do it very, very well. And the risk there of them potentially contaminating the ultrasound probe surface is low. However, then you have someone who is relatively new in doing this, and they don't really have the experience. And how many of you have observed that they're moving it around and doing it again because they can't get it right, and they're getting closer to try to approximate it, et cetera, et cetera. And here you have all of those. Now you have the places. So you might have places that maybe you have not visited or maybe visited once, and maybe that was not your focus in terms of their ultrasound use and how do they use that. In other words, the question is going to be, what do you use this for, who uses it, and how do you reprocess this? And it's not to come out there to point fingers to anybody. I'm not going to advocate anything like that. You're basically trying to find out facts here so that you can make a real judgment based on some of the information that we are providing. And then we get here into the actual procedures that are done. And there is a huge list of procedures that are involved with ultrasound probes. And I don't think that we have a slide here. At the lecture at 9:30, we do have a more comprehensive list of those kinds of procedures. So standardizing departmental policy can address practical limitations. A robust policy that has been standardized across departments can address this complexity. 92% of survey participants preferred the standardization of policies. Who doesn't love that, right? It's on paper, you educate people and you say, this is the way that we're going to do it. And even if it's done by individual departments and who does it there, that this is really a good thing. 66% of survey participants believe that their policy needed updating. So this is definitely a vast area where we need to do a lot of investigation and put our expertise into this. Staff prefer automated reprocessing technologies. 93% of survey participants prefer the reprocessing automation. Automated technologies provide consistent and reproducible cycles every time. Reduce the amount of user decisions and reduce the likelihood of human error. And on top of that, automated technologies also provide a solution for traceability of reprocessing cycles. So that's very important. So in other words, you want to be able to document that the probes, these devices, are being processed in the correct manner and that you have a record of each time that that is being done. The importance of implementing probe reprocessing traceability across your facility. The ability to verify the history, the location, or application of an item by means of documented recorded identification. And traceability is essential to verify conformity to standards and guidelines, product recalls, God forbid, outbreaks, God forbid even more, investigations, and certainly case studies. So managing traceability for external probes can be very complex, but without the things that I just mentioned to you, this could be almost totally non-existent. You could walk into a department, you could ask them all these questions, it looks good, and then you say to them, okay, what patients was this used on? And they'll go, well, I don't really exactly know about that. So you could see from this slide that it's very, very important of how we go about doing this, and this is part of the toolkit that we implemented as well. So your options for managing traceability at your facility is data collection and options available, and it has to do a great deal with time as well. I'm not going to read all of these for you, but these are the kinds of things that you really should have documented, and some of it can be automated so that it'll make it much easier for your facilities in order to do these kinds of things if you need to go back and trace everything. Semi-automated traceability is printed labels or logbooks. So how many of you have gone into any place where you have these items that need to be either high-level disinfected or sterilized, and you look in there and they're logbooks that it's all handwritten, and you say to them, oh, wait a second, what happened on this date? You know, this is missing, or this was not done. So it gets to be a lot more difficult. Fully automated will then, you could do that through actual scanning, and these kinds of records then automatically upload into computers so that you'll have the records and you could print everything out and you'll have automatic records on the operators, the time frames, the process itself, and of course the patients that this was used on. For practical, comprehensive, and editable tools, as I mentioned to you about the toolkit, to help facilitate standardized reprocessing and use was formulated. And there's an instructional video by Amy Nichols, and you could access it right at this site that you see here. So in summary, the following. In recent years, the ultrasound reprocessing landscape and the potential associated infection risk has been an area of continued discussion. Federal guidelines and our lovely Spaulding classification provide the fundamental framework for choosing how to reprocess your ultrasound probes. The ultrasound reprocessing toolkit was developed then to assist facilities to implement best practice to optimize patient safety. So thank you very much.